Hello, this is Hyatt Regency, CVI 2019, Denver, Colorado. With me is Dr. Marwan Saad. He's interventional fellow at Brown University, and recently he has published a very interesting paper related to thrombocytopenia and TAVR. Welcome, Marwan.
Thank you, Chadi. It's great to be here in CVI 2019.
Yeah. Tell us about the paper, please.
Yeah, sure. So it's an interesting paper. We wanted to target a challenging cohort of patients, and those are patients with chronic thrombocytopenia. We have learned from previous studies that these are patients are high risk. However, interestingly, these patients were actually excluded from all the big trials of the TAVR. These are patients with levels of platelets less than 150,000. And as we all know with TAVR, there are a lot of interplay between the bleeding risk and the cardioembolic risk. We know that bleeding risk can go up to 15%, major bleeding, life-threatening bleeding, and also cardioembolic risk is an ongoing concern, and we're not really sure whether we should put all these patients on antiplatelets or we should escalate up to anticoagulants and all that. So we wanted to target this cohort of patients. We looked at the National Inpatient Sample Database from 2012 to 2014. We found about 38,000 TAVR hospitalizations. Out of these was about 7,000 chronic thrombocytopenia patients. We performed propensity score matching to account for all covariates that can affect the outcomes. And we looked at the main outcome of all cause in hospital mortality. Secondary outcomes included multiple outcomes like stroke, myocardial infarction, vascular complications, need for blood transfusion, and all these secondary outcomes. Interestingly, we found that the percentage of chronic thrombocytopenia patients in our cohort, TAVR cohorts, is actually about 18%. So we're talking about 1 in 5 patients will have levels of thrombocytopenia ongoing TAVR procedure. Thankfully, we found that all-cause mortality was similar. However, they had worse secondary outcomes. They had more vascular complication. They had more need for blood transfusion, cardiac tamponade, need for ECMO after the procedure. Yeah, so
which is not surprising to see that in TAVR.
Right, it's intuitive. Yep. The good thing is the mortality was similar in hospital, so that is encouraging not to shy away from these kind of patients, and but also to pay a close attention to the platelet count. Sometimes we look at the platelets, we found it's 130. We say it's not bad. We go on. We have to really categorize patients if they are in the level of the chronic thrombocytopenia.
So what do you recommend if that's have a patient going for TAVR, given
right.
the life?
Yeah, we have to be extra careful with our vascular access. We have to be extra careful with the bleeding complications after. We have to act really rapidly if we find that they are having complication, because we know that the risk of secondary complications are higher. So we usually tend to get a little more careful if the platelet count is less than 100 or even less, but I would recommend that we pay attention to the 150 level from the results of our study, and be more careful with these patients compared to the normal.
Did you do a propensity matching or adjusting for PAD in this cohort?
Right, yes, we actually adjusted for about 25 variables, including diabetes, hypertension, peripheral arterial disease, and all that. Yeah.
So despite that, still you saw the increase in bleeding.
Yes. So I would recommend or conclude from this study that chronic thrombocytopenia is not uncommon. It's 1 in 5 patients, and we should continue to do TAVR in these patients, but we should be extra careful.
So like any other comorbidity, pre-planning,
right.
Proper approach.
Yes.
Thanks so much, Marwan, for your time and sharing your delightful results. Please watch this video and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado.